Hello, everyone. Thank you for joining us this afternoon, or it's afternoon where I am. I'm calling from Nashville, Tennessee, at our headquarters for the National Healthcare for the Homeless Council. So you are joining us today for safety and security for mobile health. And we're specifically looking today at addressing internal risk factors. So my name is Cindy Manginelli, and I'm the Director of Community Engagement with the National Healthcare for the Homeless Council. If you're not familiar with the council, we are a national training and technical assistance program, and we support those who are providing direct services to people experiencing homelessness, primarily around the category of healthcare. And so we do research, education, training, technical assistance, policy work, all kinds of things at this intersection of healthcare and homelessness. So I invite you to go to our website. You can see it here at the end of my email address, nhchc.org. I know many of you are joining us today because of your association with the Mobile Healthcare Association. So we're really grateful for our friends at MHA and the partnership we've had this year in the Leon Lowenstein Foundation grant. And so the Leon Lowenstein Foundation has funded this project, and we're super thankful for their generosity. So if you were not able to join us last week we talked about external risk factors. And Brandon, I'm not monitoring the chat, but if there's something in there I need to see, feel free just to point it out to me. Last week, we looked at external risk factors, right? As we think about mobile health. So we pull our mobile health unit up. What are the things in the environment? What are the things in the community that could potentially be a risk? We talked about the importance of doing community outreach. We talked about, we had a guest from Circle the City who talked about doing months of outreach before they ever pulled the unit out. So meeting the people that live there, meeting the people that work in that community, that was a big part of last week's session. We talked about your safe patient wait area. Where do your patients congregate? And what can you do to make the most of that time and that space? We talked about community contacts, people in the community who have your back, who are going to tell you what's going on in that community, tell you if there's something there that's changed that you might need to know. Good friends, good partners within the neighborhood. We talked about developing policy around contraband, and if someone brings something into the unit that may be an illegal substance or something that is a weapon or could be used as a weapon, we talked about how you would develop a philosophy for dealing with that and different options that we're seeing in mobile units across the country. We talked about the potential use of security personnel and hiring security guards and different options for that, different options for training security guards. That was part of last week's training. And then we also talked about technology that can be used around the unit. So we'll have that recording. We're going to send it out to everyone who's registered for either session. So you'll get a copy of that if you weren't able to join us. We had several people reach out to us and we're really excited to keep that conversation going. We mentioned last week that here at the council, we're doing a lot of work around safety and security. And last year we did over 10 hours of listening sessions with patients and providers, many of which are engaged in mobile healthcare, all of which are involved in healthcare for the homeless and working in health centers, many who also do mobile work. And so a lot of what we're going to talk about today comes out of those listening sessions and comes out of those conversations. We also talked last week about sort of the awkwardness around talking about safety and security, the reality that safety and security, what feels safe, what makes someone feel secure is certainly different for almost everyone in different situations. So it can be very difficult to be prescriptive around safety and security. I think another issue around safety and security that makes it awkward to talk about is that probably everyone listening to me today is very aware of the fact that people experiencing homelessness are often perceived to be dangerous. People in poverty are often perceived to be dangerous, to be desperate, to be contagious, right? There's been a lot of research done around that. Why are we repulsed by people who are in poverty or people who are homeless? And a lot of that goes back to our fear that they're dangerous. And so when we talk about safety and security, we can be afraid that we're going to reinforce that stigma and that bias against people who are unhoused. And so I think it's just good to say that right up front. You know, that's not what we want to do. We want to be able to practically talk about safety and security. And we also want to address the fact that we're working with a population of people who are incorrectly perceived as being dangerous. However, I will also say that according to the American Hospital Association and research that they did, 44% of nurses reported experiencing physical violence during the pandemic. This is not 44% of nurses who serve people experiencing homelessness. This is 44% of nurses serving in the country. 68% of nurses serving in our country who responded to this survey said that they had been victims of verbal aggression during the pandemic, during the last 2 years. This is a significantly greater figure than what we've seen in the past. So in the population at large, safety and security has become more of a concern. And so this is a relevant conversation in the healthcare field in general. And we are just taking that larger conversation and making it specific to mobile units. And that's really what we're going to do today. There's some kinds of building blocks, some sort of foundations that we can lay when we talk about security and talk about things that say, this isn't directly related to safety and security, but it is a cornerstone for making your staff feel safe and your patients feel safe. And one of those is your team dynamic. I was with a mobile unit. I've done some work with mobile units. I've sort of done some ride-alongs several times over the last few years. And I was with a unit and we rode into an area, and this particular unit came to this area every month. So they had a rotation, and they were in the same locations every month, but not in between. So we rode up to this location and we just gotten there. And so there were 5 or 6 staff members out front setting up chairs and getting everything set up. And then there were patients starting to gather. And this one patient just sort of exploded into the scene. And she came up to the mobile unit, and apparently she had been a patient at the mobile unit the month before and had been given a prescription, but when she went to the pharmacist, it wasn't there. And you could tell that this had just been building in her, this anger, for the last month. She had been in pain. She was concerned about her health outcomes. And for the last month, she had just been stewing in this. And so she comes up to the mobile unit and she is screaming. And as she's talking, she's beating her hand on the side of the unit. And so the unit is kind of shaking. I mean, she is just furious. She's screaming things at the patients, telling them they should go home because we could probably kill them all, screaming things at the provider, screaming things that were this is pretty much a threat at this point. She was just out of control. So you got 5 or 6 staff members there. One staff member immediately ran. He just bolted. He was just terrified. It just really scared him, and he ran. Another team member, her eyes got really big, and you could tell she was just really trying not to cry. Another team member came out of the unit and with a lot of authority. He was loud. He was very assertive. If you don't stop right now, you're not going to receive care here. If this continues, we won't even be able to stay here today. Shut it down, or we're calling the police. Very firm, very authoritative. And another staff person walked up and said, "Why don't I buy you some breakfast and we'll talk about this some more," and walked off with her. 2 staff members had no response at all. They just kept setting up chairs. They didn't even feel like it was an emergency. So you can see how in this team dynamic, not only was the team's response really inconsistent, but the team's response did not, it was dysfunctional in that team members did not feel supported by one another, right? So the crisis of this sort of explosive patient lasted for like 35 seconds, right? But the long-term effects was disunity on the team and arguments and all kinds of follow-up meetings that had to happen because the team members did not feel like they were supported. The gentleman who came out and was very authoritative felt like the woman who took her to breakfast really undermined his authority. The woman who took her to breakfast felt like the team member who was assertive was way out of control and was over abusing power, right? They all kind of felt like the one team member had just abandoned them and felt like the 2 team members who kept working just weren't paying attention. So it caused disunity. The 35-second incident with the patient was resolved. This disunity can last forever, right? And so this is the nature of safety and security issues. If people don't feel safe on the team, if people feel like their safety has not been respected or has been violated, this can cause long-term dysfunction on your team. Whereas if you have a team that feels like We know how we're going to respond in an emergency, in a physical threat, and we are going to respond consistently. We know we've got each other's backs. We know we support each other. We all agree on what is a crisis and what is not. We all know when we're going to have a big response and when we're not. We understand our designated roles. Who on the team is the designated responder, right? And how am I going to respond if I'm not the designated responder? We're going to talk about more of that in a little bit. But a strong team dynamic goes a long way to promoting safety and security. And so I know sometimes this is hard on mobile units because sometimes your team is constantly changing and you may not know who you're going to be going out with that day. Ideally, when we think about safety and security, your team would go through training together. They would role play incidents. They would be very self-aware. I know how I'm going to respond in a situation like that. Man, I know that my tendency is going to be, I'm going to want to bolt. I'm going to want to walk away. And I can talk through that with my team and they understand why I feel that way. And expectations are put around me based on that. So they would have role played, they would have discussed, they would have debriefed situations where people didn't feel safe. And so they would really understand what the team dynamic looks like in a physical threat. If that can't happen because your team is constantly changing or you never know who's going to be assigned to the unit, then at least some sort of preliminary conversations. Starting the day off with some sort of huddle. Okay, you're a designated this, you're a designated this, right? Some sort of way of encouraging self-awareness and awareness of one another. Anything that you can do to strengthen that team dynamic, because in a crisis, if it's every man for himself, again, that's not going to effectively address the crisis, but it's also not going to, it's also going to cause a long-lasting potential fear and disunity among your team members, where people come and they don't feel safe even when there's no threat, right? I don't feel safe because I feel like this person is going to respond this way and I'm not going to be safe in that situation and they're not going to take care of my needs, right? And so that can actually cause a long-standing threat to security when other threats aren't present. So the need for consistency, having boundaries on your team. I've done a lot of direct services and I have had this mentality, and I have worked with people who had the mentality that because we're serving people in crisis, because we're serving people who have experienced trauma and stress, we're going to get yelled at. I'm going to be cursed out every day. People are going to say terrible things to me. I'm going to be verbally abused. I may get slapped around a little bit, right? We can almost have that mentality of this is just part of the job. Now, some of that depends on your mission and how, what sort of culture you all have created in your unit. That may be really what you've all decided. And if that's the case, then that's your operating philosophy, but everyone on the team would need to agree about that. Personally, I think, again, as someone who tends to go, well, they're going to talk to me like that. They've had a really bad day or they're in really difficult circumstances. As I've sort of aged and been in this process longer and done direct services longer, I've come more to the conclusion that I'm not really doing anyone a favor by letting them think it's okay to talk to people that way. That if I let them talk to me that way, then they go and talk to their new landlord that way, or their shelter provider, or their campmate. It's going to be bad, right? So I need to instead model, how do I have a conversation with someone who's being verbally abusive? But that's up to you. But we can sort of develop this culture of, yeah, we're all going to get yelled at. And if staff don't agree with that, then that becomes a less safe environment for them. And so all of us understanding, what do we tolerate and what do we not? Sometimes a lot of units can find it helpful to even have a sign that they put out front or that's hanging in the unit that says no abusive language, no, this is a violence-free zone, no verbal violence, no physical violence. And then that's something they can kind of point to and go, I feel like this is getting a little tense. I just want to remind you, right? We want this to be a civil conversation, right? How can we keep this, I know you're frustrated, but right, something that you can kind of reference back to. But everyone agrees on what is violent, what is unsafe, what will be tolerated and what will not, is very helpful. Along those same lines, kind of when do we call it? Who has the authority to do that? Who has the authority to say, you know what, it's just not safe here today? Who has the authority to say this patient is not safe? We're not going to be able to see them. We're going to have to, they're going to have to be dismissed or suspended from receiving services. Do you have that line, and what is it? We've probably all been in situations where a staff member who had no authority said something like, get out, we never want to see you again. So we can't do that, right? But we also don't want to perpetuate situations that are unsafe. We don't want to create a situation where a patient comes in and does something that they're going to be arrested for. It's going to have long-term effects for them. So for the safety of patients who may struggle with escalation or instability, and for the sake of the staff, and for the sake of all the other patients who are there, what is that line? And your team needs to know what that line is, and they need to agree on it, right? And then how will others respond to me if I admit that something scared me or that I feel unsafe? Basically, am I going to get in trouble if there's a big incident? I was working in a domestic violence shelter several years ago, and we had a client whose blood sugar was really low, and I did a really stupid thing. And she was trying to take her blood sugar, and she took her blood sugar with a dirty syringe. That's how she did it. It was less than ideal on many fronts, but she had this dirty syringe in her hand. She was also blind, and her blood sugar was low. So I was helping her take her blood sugar, and turned around. So many mistakes made. Turned back around, and she stabbed me with the dirty needle, completely unintentionally. Her blood sugar was low. She was just out of control of her body. And my first thought was, I'm going to be fired. Oh, they're going to fire me. Because you're not allowed to get stabbed by a dirty needle, right? It wasn't an environment where I felt safe to say, okay, I made a mistake and a physically dangerous situation resulted. What's going to happen if I do something, if someone yells at me, if someone slaps me, if someone is escalated and I'm the staff member they're working with? Am I going to get in trouble? Is everyone going to say, what did you do wrong? Is there a safe way to debrief? If I'm just with a patient and that patient really makes me feel unsafe, can I say that? In what context can I say it? Can I be offered support? Or if I say that, am I going to get fired, or I'm going to get suspended, or I'm going to have to meet with somebody? And, so all of these factors help to having clear policy around each of these issues helps you to have a team where people come to work, and whether there's an incident or not, they come to work and they feel safe. Right? It's a culture of safety that's really the foundation for a lot of what we're going to look at over the next few minutes. So also, right now we're looking at before the trauma, what we can do in preventive ways. Staff training is going to be huge, and I know that sometimes that's hard. You may be in a place where staff don't really know whether or not they're going to be serving on the mobile unit. I know some of you are at locations where you have a mobile unit team, and that's what they're trained to do, and that's what they do every day or so many days a week. Others have programs where it's kind of like, who's going on the bus today, right? And it's not as premeditated. And so these trainings can be tricky. We work with health centers across the country where every member of their staff has to do de-escalation training. Every member of their staff. And I'm a big proponent of de-escalation training. We offer, I do this de-escalation training. We're going to be adding it to our website here soon around some safety and security work we're doing. So I hope that very soon this will be something that we can offer even just on our website. But de-escalation training, conflict resolution training, all of these things will go a long way towards, again, helping your staff to feel safe, whether there's an incident or not, then to actually respond. But if you're not going to do sort of a full-on de-escalation training, the most basic component of de-escalation training in its purest form is what you're looking at here are, what are the signs of escalation? What are signs that someone is losing control? That's really what de-escalation is about. It's not that we've lost control of the other person. That's not at all what it's about. That's not really the goal. That the person has lost control of themselves. My volume, my gestures, my thoughts, what I'm saying, what I'm thinking, what I'm feeling, my body is all getting bigger and out of control. De-escalation can also mean that all of those things are getting smaller, right? I'm shriveling up inside myself. I can't speak. I can't think. My feelings are overwhelming me. Sometimes this can happen just in a panic attack and something that's really gonna be over, in 5 or 10 minutes. This can also be something that just builds and builds, right? And so just understanding what are the signs that someone is escalating is a big part of just the most basic elements of de-escalation. What does it look like when someone is losing control, right? And de-escalation is not just about, we really want to get this under control because we don't want something bad to happen in the unit. It's also about, we don't want this person to do something that results in a loss of freedom or a loss of, things that are important to them, their children, their job, their ability to get healthcare, right? So what is the difference between someone who is losing control and someone who's just loud? Some of our patients are just loud, right? Many of you are thinking of patients as I say that. Many of our patients are loud and they're expressive and they have big gestures and they tend to be very physical, and they may slam their hand down when they're talking, or they may kind of, push something when they're talking, and they get really loud, but they're in control. That is their baseline. So being able to identify that. And then also, I think 50% of de-escalation is, what am I, as the helper, what am I experiencing? What are the signs that I'm losing control? I'm feeling defensive. I'm feeling like, hold on there. Like I have to get control of the person. Like I'm being disrespected, like I'm being ignored. What does that look like in me? What does it feel like in my body, in my heart? I'm starting to say things that, I shouldn't say that, right? I'm starting to get overwhelmed by my feelings. Because often what happens in escalation situations is that the person who's trying to help makes it worse by doing things that just cause the person who's struggling to struggle even more, right? By saying things that make them more agitated and more anxious and feel more aggressive. And then we're just bouncing off each other. And so a big part of de-escalation training is just identifying that feeling in myself, and then how will I respond? How do I keep myself grounded? How do I keep myself under control so that I can provide help? Or if I can't, what do I do? How do I walk away? How do I excuse myself from the situation? And how do I develop language around that and the humility to do that? These are all things that you would want to practice with your team, talk about with your team. Also, the signs that someone is struggling with substance use. If someone's high or intoxicated, a lot of conflict resolution skills aren't going to work at all, right? But what are the signs that someone is under the influence of something and that's causing them to feel out of control? And then what do you do with that? Do you make referrals? Do you ask them to come back later? Do you have a space where they go and kind of hang out for a while? What is your response to that? Same thing with a mental health crisis. If you've ever had a panic attack, then you know that feeling of, oh my goodness, I'm feeling out of control, right? If you've ever experienced psychosis, or you've worked with someone who's experiencing psychosis, then you know that can be really scary. And so helping someone knowing what that looks like, seeing the signs of that. This is not an issue of we need to sit down and have a conversation. They're experiencing something in their body and their mind. It's going to make it really hard to process verbal conversation. So what do we do? What is our response to that? We all know and we all agree. And then signs of a physical health crisis. I talked about the client I had with low blood sugar. She was a physical threat because her blood sugar was so low. She was yelling. She was thrashing around. There was no amount of conflict resolution that was going to fix that. But so what are the signs of that? How can we know that? How do we respond? Same thing with someone with really high blood pressure, or someone who's taking medication that limits their ability to regulate their mood. All of this. How do we communicate about this? What do we do? Are things that your staff need to be trained on and communicate about, and refresh those communications regularly. So the use of electronic health record around this is a little controversial. There are some programs that feel very strongly one way or the other, but I just want to throw this out here as an option. And that is that you can use electronic health records as a way of communicating about patients who have struggled with aggression or with violent acts in the past. And so obviously what the danger of that is that a patient could come in and I open up their electronic health record and I go, oh, wait a minute, even though I've never met them, right? So we don't want to do that. But there also can be valuable ways that we can use electronic health records when we're working with clients who do have a tendency to be more aggressive. So what some programs do is they just have a flag that pops up. If it's a blue flag, then I know sometime in the past, at some point, they did something that was considered threatening or aggressive. And that's all I've got. Others will, have a flag or a code or something. But when I go into the notes section, I can see exactly, what happened there. And so the advantages around that are I can then use a strengths-based approach as I interact with that client. What's worked in the past? If we've continued to see this patient, how have we navigated those situations? What kind of support did we put in place that was helpful? Were there specific staff members who really connect with this patient? What have we done that worked? And so an electronic health record can be a way of doing that. And it can be a way of doing that that's better than Nurse Susan and Nurse Adam get together and say, oh, it's them again, right? It can be a very standardized way of talking about what's happened in the past, what's worked, how do we move forward, and a very recognizing the dignity of the person that we're talking about. Also, you could note their specific triggers. This person is not interested in seeing the social worker, and when they go see the social worker, it doesn't go well. That's not what they want to do. So let's take that off, even though that's a typical part of the workflow. Let's respect that. Sometimes it allows you to have notes there that allow you to make changes as opposed to just hoping staff remember that. You can also note trends. Was this this client that I had with the low blood sugar, she wasn't violent, she wasn't aggressive. She didn't, if we were going to note somewhere that she stabbed me with a needle, with a dirty needle, we would want to be able to know that that was a one-time thing, right? When this person is in treatment, they tend to be more aggressive, or when they're not in treatment, they tend to be more aggressive. Whatever. Are there trends that we can identify and offer support when it's needed based on the trend? Again, all of this is about offering support. And then also some health centers, some units will say, once someone, kind of a 3 strikes you're out kind of process, for lack of better wording. We're going to document on this date, we had this conversation, this incident occurred. We let you know that this can't continue. To be able to go back and be able to really document, we've had these hard conversations, but we just don't feel like this is working. I talked to a unit actually this week where the patient was unable to be seen in the brick and mortar building. And so they were seen in mobile units and because of acts of physical aggression, and they were very aggressive in the mobile unit. And so eventually it was determined we're going to just go out and see them through street medicine, through a doctor with a backpack on is going to go check on them. And so they were able, by looking at the documentation and identifying trends and seeing triggers, they were able to say, this probably just needs to happen outside. And so there can be some value in using your EHR this way. Let's talk now about the physical environment of your unit. Physical environment is huge. Much like we talked about the foundation for safety and security set by your team, your physical environment sets a huge foundation for safety and security. And unfortunately, in a mobile unit, this is where we kind of hit a wall, right? Hopefully not literally, but we kind of hit a barrier, because there's very often not much you can do to control the interior of that unit. Everything's drilled to the floor, right? Everything's pretty much set. You don't rearrange a lot of furniture in most units. Sometimes you have some options, but this makes altering your physical environment tricky. We can look at a few things here that might help. Number one factor when you're looking at the physical environment in which you treat patients is, are they trapped? If you've ever had a panic attack or experienced psychosis, or even just experienced a lot of extreme acute stress, or if you talk to people who've experienced those things, you know that one of the key things you feel very often is trapped. Trapped inside your own body, trapped in location, trapped by the circumstances, trapped by the way you're being treated. And very often, that's a common theme, is feeling trapped. And so you want to do whatever you can so that patients and staff do not feel trapped. And that is hard in a mobile unit if you're, both sitting in a room the size of a small closet. But if someone is beginning, you sense tension, you sense agitation, anxiety, we want to, as much as possible, emphasize, here's the door, right? There's nothing between the patient and the door. We want to keep it, we may need to keep it open. We may need to gesture toward it. Sometimes when someone is beginning to lose control, we have this feeling of we better keep them in here, right? We better contain it, which is often a terrible mistake. First of all, you can't legally do that probably. You're not really equipped to do that probably, but also it will almost always cause the person to feel more escalated. So always want to make sure here's the door. Now I may have to be thinking about, okay, if this person is experiencing a lot of stress, a lot of agitation, they're becoming aggressive, who's outside the unit once they run out, right? What does that communication with those outside the unit look like? But in general, we don't want to try to do anything that makes someone feel restrained. So when someone, if I'm in a tight area and someone's beginning to express agitation or become aggressive, my language needs to be around, wow, this space is beginning to feel really small to me, or I feel like we've got tension in the room. Let's step out. And I step out and I am modeling we're going out, right? I want to do whatever I can so that no one feels trapped, including your staff. If someone loses control within the unit, what are the risks? What are the risk points? What is hard? What is sharp? What probably needs to be locked up? What are the danger areas? And I encourage you to walk through your unit and identify those places. I encourage you to have people who know nothing about mobile health, who have nothing to do with healthcare, walk through your unit. But what are the places where, okay, if someone loses control here, we're going to be in a mess, right? We do this when we talk to victims of domestic violence. What are the safe places in your home, right? And this is where context is huge. So someone can have big gestures, and they can be someone who's very physical, and they can yell, and they can, even by themselves, they can, yell and push things and stomp outside their tent. Who cares, right? It's no problem at all. They can do the same thing in the waiting room of a large hospital. Not as good. Possible that you could do that and not really hurt anyone. Definitely, probably make some people uncomfortable. Inside a mobile unit, the exact same thing that they do outside their tent every day could get them arrested, right? Me and you in this tiny little area. So context is huge when we think about safety and security. And unfortunately, mobile units provide a context which is pretty restrictive. But patients may not understand that what you do even outside the unit, when you come in, it's got to be smaller, right? So identifying, if someone is got big expressions and big gestures, what are they going to hit in this room? This room is a dangerous place for someone like that. This room is a dangerous spot for someone who's getting agitated. So the staff who work in that spot need to know that and need to have language and practices at the ready that they can employ if someone becomes agitated. I've been on a few mobile units where the lab, where they draw labs, is this tiny little space. And so you've got all the needles and you've got all this equipment, and it's the smallest space, and it's the space with the most sharps, and it's the space where most patients feel the most anxiety. And so, boy, that staff member needs to know that, right? I'm in this tiny little area with all this equipment, and most people are scared to death when they sit down. So what do I do? Hey, you seem really anxious. I know this is scary, and it sounds like you've had a really long day. Do you want to sit outside for an hour and come back? What are our safety measures for that? So knowing the worst places in and around the unit, also knowing the safe places in and around the unit. If someone is becoming really agitated, where can we go that's safe? I've referenced a few times saying to someone, hey, I feel like I just need to go outside and get some air. Like this feels a little tense to me, or I'm feeling a little uncomfortable, a little anxious. Can we step outside? Where are you going to go? Knowing what is that safe place. If someone is under the influence of a substance, or someone just needs a quiet room kind of place, is that something you can offer, and where would that be? Is there sort of a de-escalation area? Is it possible? Is it allowed to take patients outdoors if they're becoming escalated and agitated within the unit. And if it's not, then what is your plan B, right? All of this around your environment when you can't actually necessarily move around a lot of furniture and things. I know mobile units that operate out of basically a minivan or a, you know, a 16 passenger van. And so when that door shuts, right, it feels pretty confining. So doors, windows, light is huge. How can we bring in more light? How can we bring in fresh air? What does the unit smell like? What does the unit feel like to people? All of these are things that contribute to safety and security. A lot of units use mirrors too, so that in the key places where staff sit and stand, we can all see each other. And so I can, you know, I can see what's going on when I hear this, when I hear someone getting loud or I hear a situation developing, I can see as much as possible. Lights and mirrors, it sounds kind of creepy, but I think I've seen a lot of units use that creatively in a way that was really helpful. So now let's talk about in a crisis, if there actually is a crisis. So communication and documentation are going to be the two main things that we focus on here. We've already given a lot of examples of, you know, what we're watching for, how we're responding as people begin to feel escalated. But in a crisis, how are we going to communicate to one another and how are we going to document that? I mentioned this earlier that it may be really helpful to post around the unit or in the unit that this is a non-violent space. And a little bit of language around what that means. We're used to seeing those signs, I think. My son played soccer last year and there was a sign up saying this is a nonviolent zone and explaining that. So something that we can kind of patient see and we point to and as a reminder. So how do staff communicate that an incident is in progress? We make a lot of mistakes around this sometimes, I think. Saying something like, hey, I've got a code blue over and, you know, I got a code blue over here, or, you know, a code word or some sort of sign that I do very often creates more anxiety. I don't know if you've ever been shopping through walking through a retail store and it comes over the, you know, comes over the loudspeaker. We've got a code 7 in cosmetics and, you know, you're immediately, am I in cosmetics? Am I the code 7? You know, it creates more aggression. When an incident is in progress, as much as possible, we want to offer clear communication. We don't want there to be secrets. We don't want there to be things that cause the patient to feel less control, more of a sense of what's going to happen to me. That's probably some of what started the incident to begin with, right? Things like, you know, I feel like you're getting kind of upset. I'm going to ask Susan to step in because I think she might be able to handle this and give us some insight. I think Susan might be better at this than I am, right? Oh, I see that Susan's in the other room. Let me ask her to come in. So I'm very clear about what I'm doing. There's no code. There's no, Susan, I need to, you know, can I see you for a second? Or, you know, how can we communicate so that we know what we're doing, but it's also very clear and open and appreciating the dignity of the client. I'm just going to send a text real quick. I'm not really sure that I'm handling this well. So I'm not really sure how to move forward. I'm not really sure what to do next. Seems like you're feeling a lot of tension. Let me just send a text real quick and see if I can find someone who can help. Whatever you can do, but you need to have language around that that's not vague, that's not mysterious, that's not secretive, right? I even encourage people, if you're going to call the police, to be really clear. I just want you to know we have gone ahead and decided to call 911. This just is feeling really scary for us. If you've called 911, it's not going to be a secret for long, right? It's going to be this huge mass, and so of sirens, and you know, so be very clear about what you're doing, right? Unless you feel like that is going to cause a much more dangerous situation. I find it is much better to have told someone that than to all of a sudden they hear the sirens. As much as possible, clear communication. Having some way that we can talk quickly, whether that's a group text that's always up, a push to talk sort of function on your phone, a walkie-talkie, but something that I don't have to go find my phone and figure out, hold on, let me look up. You know, there does need to be a really clear way that we can quickly, instantaneously communicate with one another. And sometimes that's an advantage to mobile units, is that you can hear everybody anyway, right? But I need to be able to quickly talk to whatever staff I have outdoors, and sometimes be able to very quickly talk back to the people at the brick and mortar facility. And then having specific team members who are assigned to offer support, or specific staff who know that they are not. I mentioned the team scenario at the beginning. we can see from that scenario, there were some team members that you're not going to call on if someone's escalated, right? The guy who made her run for it probably isn't going to be your go-to. And he would probably find it comforting to know no one's going to call me in those situations. I can keep doing my thing, right? So who are the team members who can offer support? What kind of support are they going to offer? Hopefully everyone has received some sort of training, but having a designated team member, some mobile units use the driver, that the driver knows if someone's, that the driver also sort of serves a security function or a de-escalation function. Sometimes it's someone outside the unit. So who are we going to call? What are they going to do? And this is something that ideally you would role play. It would be very, you would have muscle memory around this. This is just exactly what we do, right? What point do I call that person? What does that phone call look like? If you have a policy that says, in the event of physical aggression, call Bob, you have a useless policy. What does it look like? What am I going to say? How is Bob going to know what I'm saying? What's the client going to hear? How am I respecting the dignity of the patient? What does that look like to call Bob? Why Bob? What if Bob's not there? What is Bob supposed to do? Is Bob going to show up and say, you called me for this? Right. All of this needs to be practiced and written down. And that morning huddle, everyone knows that, right? When are you going to call help from law enforcement or from crisis intervention or from some other sort of community help? Who makes that call? This is another one that we see a lot, is that people don't know how to call 911 and don't know when to call 911. Many mobile units will partner with crisis interventionists in the community to have a specific agency that they reach out to. Sometimes representatives from that agency will be there providing services, in the waiting area or whatever. That's always cool. But sometimes, we know in this situation, this is who we're going to call. But if you have, staff or volunteers who kind of, have a knee-jerk reaction to call 911, that can be a problem, especially if no one else realizes that they're calling. And there is a skill around calling 911, right? Do your staff know what the person on what the operator is going to say, what the dispatcher is going to ask for? We do a whole nother training on how to call 911. But that is significant. If you have someone pick up the phone and call 911, and they say, oh my goodness, there's someone out of control and he's going to kill us all. And we're all, and they kind of freak out on the phone. 911 has to respond with what you say. And you can have a SWAT team and a huge issue there just because there was an inappropriate 911 call made or language wasn't clear. So who do we call? When do we call them? Do we know how to make that call? And again, good things to role play and discuss as a team. And then having clear policies around how we're going to debrief and how we're going to document this. So that would go back to some of our EHR conversation, but there should be, anytime anyone has felt unsafe, there should be a way that they debrief. And sometimes there's a debrief, like with HR, with administration, that's very formal. Sometimes there's documentation that's submitted that's very formal. This is what happened, just like a case note. And then sometimes some units too will have a setting where we debrief where it's very informal. And the people at the debrief do not have the power to fire anyone or to make a formal record, right? It's just a safe place to talk about what happened. So what kind of debriefs do we want to offer? What are the purpose? So that the incident is documented, but also so that we've taken care of everyone. Also thinking about how are we going to communicate with other patients? If something happens like, law enforcement has to respond and there are sirens and someone's being, if there's a big incident, even the incident with the woman that I told at the beginning who was banging on the unit, every patient who came in that day started off with, wow, are you guys okay? That was really scary. Or what'd you guys do to her? How are we going to answer? That respects the dignity of the person who was experiencing all that, aggression and anxiety. And that also isn't, well, that's really none of your business, right? That also helps our patient population to feel safe, right? Yeah, they seem like they're having a really hard time. I think they were able to talk to a staff member and hopefully we're able to work that out, right? But we don't want to pretend like it didn't happen, but we also want to recognize and respect. So what is all that communication going to look like? Deciding that in advance, reminding each other of that, reinforcing that with each other. And then following up and again, identifying themes. If we're having a lot of issues of violence or aggression or severe anxiety in the unit, is there something we can do to change that? And we talked a little bit about this last week. If the waiting room stresses everyone out and we keep having disagreements and episodes of escalation in the waiting room, maybe we need to change the waiting room. So regularly having meetings where we just discuss safety and security. Are our patients feeling safe? Are they feeling secure? What can we do to help? Is huge. And so what are some learning points we can take away? Some units just to have a quarterly meeting where they sit and do this. I've talked to some units where they do this every day, every time they go out. Every time they go out, they have a huddle at the beginning, and there is some nod to safety and security around that. And every time at the end of their session, they go through, okay, were there times that you did not feel safe? Why not? Are there things that we can do to increase that sense of safety? Are there patients who reported that they don't feel safe? One of the main components that we're kind of leaving out of this communication on some level is communication with the patients. And so, of course, when we have an incident, we want to have a plan on how we communicate with patients. We also want to have a way that patients can communicate to us that they don't feel safe. If they don't feel safe when they're waiting, if they don't feel safe in the unit, how can they communicate that? And so that's a really big point here too, is what does your consumer or patient engagement look like? And of course, that can be focus groups. You can have a patient advisory board. You may have something in the brick and mortar building that you can build on, but having some way that you conduct outreach with your patients so that you know what's making them feel safe and what's not is really important. So a bottom line question here, sort of a fundamental question. What is the panic button? What is the panic button? When do you push it? Who can push it and what happens? And I don't mean a literal panic button, although you may have that. But we talked about this some at the beginning, that your team needs to be really clear on this. But also as you think about in the middle of an incident, what is that? Okay, we've crossed a line here, right? This has gotten scary. This has gotten, I, as the provider, feel like, oh, I'm really not sure what's going to happen next, right? My heart's beating really fast. We're all kind of looking at each other. What is that mechanism that we put in place that says, okay, this isn't going well? What is that panic button? And everyone on your team, even if this is the only day they're ever serving, really should ideally know that. What is a crisis and what is not? And if we're really feeling like this is going down, this is getting really out of control, what do we do? And then once we decide that, what's going to happen? Are we going to call law enforcement? Once law enforcement arrives, what are we going to do? How are we going to respond to them? Having safe places that your staff can go to. This would be something you would be prepared for in the event of a natural disaster, but also of a physical threat. If this is really scary, what are we going to do? What are we going to do if a patient is in this room and we feel like, okay, we have lost control and we're in danger at this point. We're in danger. We all know how we define danger, and we are in that situation. What would that look like if the patient was in this room? What if they were in this room? What if they were in the waiting area? What do staff do? What do we encourage patients to do? Almost every mobile unit that's participated in our safety and security listening sessions, the real issue has happened outside the unit and within the community with fewer episodes within the unit with actual patients, but being prepared for each of those scenarios. What's our safe place? What's the safe place for people outside? And just having that in your mind and knowing that. And then what's going to happen if we really decide that the situation has escalated. So I hope that has given you some really clear things to think about. What I would encourage you to do with this information, if you have questions or comments, we've got I think we have a resource. Yeah, we have a resource page here too. OSHA, the Occupational Safety and Health Administration, has a really good book of guidelines. It's a little bit dated. It was written in 2004, and I did not find an updated copy, but there may be one, on workplace violence for healthcare and social service workers. And so that could be really helpful to be familiar with as a training guide for your staff. If you want other information or want to talk more about this, please feel free to reach out to me. You can see my email address right here. For us right now, safety and security is an ongoing conversation. So we are very happy to talk more. We're also happy to connect you with other units who have really thought through and been very purposeful about their safety and security procedures. And we're happy to make those connections too. What I would encourage you to do at this point is to really think about what questions, what tools can you take from this, but also what kind of conversations do you need to have with your administration? What kinds of policies and procedures do you need to write? Once those policies and procedures are written, how do we reinforce those? How do we refresh those? One of the biggest threats to safety and security is when we don't know what to do. And again, a big threat to safety and security is when people are afraid to respond because they're afraid they're going to get fired. So what policies and procedures are we lacking based on the conversation that we had today and last week? What needs to be written? What needs to be implemented? And then how do we keep those policies and procedures forefront in the minds of our staff? So how do we, from a systemic level, from a top level, what are we missing as far as policies and procedures? And then as those are prepared, how does that filter down all the way down to the volunteer who serves once a month in the waiting area of our mobile unit? What do they need to know? What do they need to do? I would hope that you'd be able to take from this conversation some of those tools and kind of implement that way. But again, we are also happy to talk more. This is a 4-part, we're doing a fall learning sessions on mobile health. And so our first session was on safety and security. We did that last week and today. Our next sessions are on a totally different topic, but one that probably causes more fear for administration than the safety and security issues we just discussed. And that is, how do we bill for services around mobile healthcare? So we've got 2 sessions coming up on that. One is on October 13th and one is on October 20th. The link that you use to register for these sessions there's a link on the same sort of webpage on our site that will take you to register for these 2 sessions. And I'm also going to be emailing out to everyone who registered for the last 2 sessions a link so that you could register for these if you're interested. The first one, we're really going to look at what do different mobile health units do to bill for services, both in expansion states and non-expansion states as we think about Medicaid expansion. Of course, this is very different across the map, but we're going to look at some different models. And then on October 20th, we're going to talk about, as we think about mobile services and we think about advocating with policymakers, with lawmakers, what sort of policy exists around mobile healthcare, and how can we be a part of informing that policy? What's our role in that? We're also going to look at what it looks like to make a business case for mobile services. So those are 2 upcoming webinars that we have. And then we have one more announcement from, I think I'm maybe going the wrong way. Let's see. Nope. From the Mobile Healthcare Association. So Elizabeth.
Wonderful. Hi. Thank you so much, Cindy, for that wonderful presentation. And I know all our members are very fortunate to be learning from the work of the National Healthcare for the Homeless Council and all the experience that you have. So I'm excited to say that we have launched a mini grant program for our membership. Applications are due next week, but it's a very short application, so you still have plenty of time to get it in. Through funding from the Leanne Lowenstein Foundation, we're going to be awarding up to 10 members $8,000 each to help build capacity for their mobile program. So, and I think there's one more slide, if you could advance the slide. I believe, right? So there are 2 options to apply for the grant. You get to choose one of the options. So one would be to invest in team training or other programming to address employee burnout and staff retention amongst your mobile healthcare staff. And the other option is to use the money to make a video that will showcase your program to be used with funders and sponsors. And both of these, either your wonderful idea on employee retention and burnout or your finished video will be shared with all of our mobile healthcare members on different platforms as well. So please reach out to us if you have any questions, but mobilehca.org is where you can find all the frequently asked questions about the grant and any other, as well as the application, mobilehca.org. And we hope that you will consider applying. The requirements are you are a member of the association and that you also have put yourself on the mobile health map. But putting yourself on the map is not an arduous process. So we hope that everyone will consider applying for the grant. and look forward to seeing you all in October for part 2 of this webinar series.
Thank you. That's awesome. That's exciting. Brandon, do we have a poll, a survey to finish out today?
We do, yes.
Awesome. We can go ahead and launch that if you want. So of course, we're going to need to document what everyone thought, how everyone felt. As you leave today, thank you so much for joining us. I hope you've received some helpful information on increasing safety and security in your mobile unit. Please feel free to reach out for more information, and hopefully we will see you in October. Thank you so much for joining us today.